exam. And let me also tell you that importantly, the recall sessions are never perfect because the questions exactly how they appeared in the examinations, at least these days when they are lengthy, little clinically oriented, it is very difficult for anybody to do an exact recall. And whatever answers we conclude may not be exactly as in the answer key of the examination authorities. The reason for that is the recall bias, right? If we know something very well, then we will be able to recall that point. But if we don't know well, we may not be able to recall. So we have to keep that in mind always. Okay. So the today's session is going to be really short. The simple reason why it's going to be short is we hardly have any question that I can say they are very own of medicine. The questions were so well integrated and most of the questions have already been addressed by the basic sciences faculty itself because they were mostly integrated questions rather than true medicine questions. Now you might ask me, sir, what is the true medicine question? A true medicine question is one where it asks you for decision making, right? It tries to test you or your ability to make a decision in the diagnostic confusions or to make a decision in terms of management. Such questions were very minimal. So let me start without wasting time to know what are the important questions that appeared. And most importantly, this session is not for those who just gave the exam and they want to know what is the right answer for a question. Okay, so you have just given the exam, your result, your fate is sealed in the envelope. Once the NBE opens the envelope, you will get to know what has happened, right? All these recall sessions will not make any difference to your result. So don't waste your time here, rather go chill, goa jao, maja karo. Lekin for those students who are preparing for the subsequent exams, recall sessions are very important because PYQs are important and the topics from which the questions are coming, they keep being in trend, right? Okay, good evening Piyush Bharadwaj. Yeah, okay, so as I've already told you, please don't go by my answers because my question framing itself may be wrong. It may not be exactly how it appeared in the main exam, but at least I can say we get to learn about the important topics. So make a list of the topics that we are covering today. That is going to be important if you are giving any exam coming up next. Okay, so this is the first question. In the question, they had mentioned that there is a female patient who is hypertensive, presented with sudden onset headache. Her blood pressure was 160 by 100 millimeters of mercury and a CT scan showed subarachnoid hemorrhage. They are asking you what is the next step in the management. Options that appeared in the exam were giving nimodipine, surgical intervention, esmolol and angiogram to find the site of aneurysm. Can you tell me what answer you would pick if you are giving the exam? Female, hypertensive, sudden onset headache, BP is 160/100 and CT showed subarachnoid hemorrhage. If I was the one person who was examining this patient or taking the history, I would have asked like how severe is the headache and probably she would have told this is the worst headache of my life, right? Sometimes examiners mention that as a Q, worst headache of my life or thunderclap headache, right? So you have to remember these words, worst headache of life or thunderclap headache. Whenever we hear this, it is a potential clue towards subarachnoid hemorrhage. Anyway, in this case, they have directly told that it is subarachnoid hemorrhage. Okay. Swapnil Gaikwad thinks that we should do an angiogram to find out the site of aneurysm. Okay. Can we use nimodipine for this patient? Can we use nimodipine for this patient? A patient of subarachnoid hemorrhage. Is there any role of nimodipine? Is there any role of surgical intervention? Is there any role of esmolol? All of these drugs can have its own role in a very specified setting. Okay. Now tell me, why do we use nimodipine in a patient with subarachnoid hemorrhage? Any logic is there for using nimodipine in a patient with subarachnoid hemorrhage? Why do we use it? Yes, we do use it, right? If you're already an intern, you already know that when you go to the ICU, patient with subarachnoid hemorrhage may be getting nimodipine. Can anybody tell me why we use it? Is there any reason we use nimodipine? Okay, the reason we use nimodipine is to deal with vasospasm. So when subarachnoid hemorrhage happens, it can trigger vasospasm. Okay, do we use it for treatment of vasospasm or do we use it for the prevention of vasospasm? Jiten Yadav, absolutely right. We use it for prevention of vasospasm. To use it for prevention of vasospasm. So it is more of a preventive strategy, right? So right now the priority for a patient who presented with subarachnoid hemorrhage is to prevent rebleeding or enlargement in the size of the hemorrhage or hematoma that has developed, right? So whenever you see any algorithm which is for the management of subarachnoid hemorrhage, the first question to ask is whether it is aneurysmal bleed or non-aneurysmal bleed. First question is whether it is aneurysmal or non-aneurysmal. That's the first question to answer. If it is aneurysmal bleed, it might require intervention, right, in the form of either aneurysmal coiling or embolization. So if it is yes, and if the patient is not responding well to conservative management, might require surgical intervention in the form of either aneurysm embolization, or you might have to go ahead with coiling. Okay, and if it is non-aneurysmal, you will manage the patients conservatively. So first choice would be to do nimodipine, or you would go ahead with a angiogram to find the site of aneurysm. What would be your first choice? As I told you, whenever you have a case of subarachnoid hemorrhage, the first question is it aneurysmal or is it non-aneurysmal? If it is aneurysmal, you might have to think about embolization or coiling of the aneurysm because there is rebleeding risk. There is risk of vasospasm. For that, you can give nimodipine, right? But the most critical question is it aneurysmal? So that answer will only come if you do an angiogram. So angiogram would be the priority. If the angiogram shows that there is an aneurysm, or if angiogram shows an aneurysm, might require surgical intervention, or if patient's subarachnoid hemorrhage has led to, let me say, hydrocephalus, the raised intracranial pressure, so you might have to do a decompression surgery. So it is a step that comes later in the part of the management. Esmolol you might consider using for the BP, but 160 by 100 is not such an emergency that you would jump to start a IV beta blocker. Not important right now. Nimodipine I would prescribe, but it is not a priority step. I would prescribe it for prevention of vasospasm, but it is not the priority step. So in this case, the priority step would be to angiogram to find the site of aneurysm. Okay, is that clear? Now let's move to the next question. This is a question. A farmer was brought to the emergency with history of OP poisoning and managed with atropine and pralidoxime. After few days, he developed high-grade fever. What is the likely cause? It's a farmer with OP poisoning managed with atropine and pralidoxime, right? So in terms of management, they have done whatever is normally suggested. But let me pose one question to you. What is the role of pralidoxime right now in the management of OP poisoning? What is the role of pralidoxime in the management of OP poisoning? And there is also another zone you need to be aware about. When you talk about atropine for the management of OP poisoning, there are two concepts: low dose atropine versus high dose atropine. So which is the preferred approach right now? So any case of OP poisoning, we try to treat them with atropine and pralidoxime, right? Atropine is one, and currently most of the authorities will prefer using low dose atropine versus high dose. Low dose is preferred, right? So please be aware of it. Low dose is the preferred approach. And the second one is P2AM or pralidoxime. Now P2AM right now is a controversial thing. Yes, it is something that can prevent enzyme hardening, but its benefits are now doubtful. There is a lot of research, especially from the CMC Vellore, which kind of counteracts whatever we believe to be true about pralidoxime. So doctors are in split opinion about it. But anyway, for the sake of exams, pralidoxime is what we also write in the management of OP poisoning. Okay, so in terms of management, the two basic drugs that need to be given, they have started. But after few days, patient developed high-grade fever. What could be the likely cause? What could be the likely cause? Can the side effect of pralidoxime present in the form of high-grade fever? Or can it be atropine overdose? Or is it the symptom of organophosphate poisoning? Or is it aspiration pneumonia that patient would have developed? Okay, so the causes for fever in any patient, not only OP poisoning, who is in the hospital, can be because of hospital acquired infection, one possibility. So aspiration pneumonia is a possibility. We have to keep that in mind. It's a possibility. It might cause fever. Okay, that is one possibility. Second, apart from infections, drugs are very important causes for fever in the hospitalized patients. We call it as drug fever. We call that as drug fever. And this is something that we cannot neglect, because when you start practicing, you will notice that sometimes stopping all the drugs solves the patient's fever problem. You do all investigations and you find nothing, stop all the drugs, we call it as drug holiday, and then fever stops. So drug fever is also a real entity. So we have to be aware. So some of the drugs may be causing the fever. Okay. Now comes the question, should I choose atropine? Because atropine overdose, can it cause fever? Can atropine overdose causes fever? Can atropine overdose cause fever? The answer is yes, right? When you talk about OP poisoning, you are characteristically drowning in your own fluids, right? There is secretions everywhere, what you call as sludge. But when you talk about atropine, right, it can dry out all your secretions and it can cause significant hyperthermia, right? Hot body that you will see. So atropine overdose can also cause fever. Now, I don't really know whether the information given in the question was only this much, or they had little more details in the form of dryness of the skin, dryness of the secretions. If that was there, atropine overdosage would have been a more definite answer. But even here, they have not given any potential clue for the aspiration pneumonia. They have not told that patient has cough or the patient has desaturated, his saturation levels have gone low, or X-ray shows that there is a mnemonic patch. They have not given any clue to point towards aspiration pneumonia. Right? So keeping that in mind, there are no pointers towards aspiration pneumonia from the patient's history. I would still prefer to go with the atropine overdosage, because that's a real common problem. When you're treating a patient of OP poisoning with atropine, there are few problems that you encounter on a routine basis. One is atropine psychosis, and the second one is hyperthermia or febrile response. So keeping that in mind, please go ahead with atropine overdosage as an option. If the examiner wanted you to commit to option D as an answer, he would have given you some additional clues, saying that patient is in respiratory distress, or patient is having productive cough, or he would have told patient is having hypoxia and he required ventilatory support. So keeping all that in mind, we have to go with atropine overdosage as the choice. Okay, now last question before we move to the next question. Can anybody tell me what is the common side effect of pralidoxime? What is the common side effect of pralidoxime? Okay, so you have to remember that when you treat patients of OP with pralidoxime, there is a risk of hepatotoxicity. Hepatotoxicity. In fact, it can cause fulminant hepatic failure. Yeah, I would go with whatever information I have, or the way we have constructed this question, I would go with option B as the correct answer. Okay. Now, the pralidoxime is associated with hepatotoxicity. It is hepatotoxic. It can cause acute liver failure in some patients. Especially there is another P2AM blocking agent which is called as obidoxime. Obidoxime is strongly associated with hepatotoxicity more than pralidoxime. Okay, so this question doesn't talk anything about the hepatotoxicity, so that's ruled out. So two things we can comfortably rule out here is the side effect of pralidoxime, and fever is not a symptom of the OP poisoning. Between these two, right now it seems safe to go with option B. Okay, now let's move to the next question. This is an interesting question. A lady noticed that her husband was being unable to express emotions. Her husband was being unable to express emotions. He also had tremors and slowness of gait. Where is the possible site of lesion? What disease we are talking about here? A lady noticed her husband was being unable to express emotion. So there is lack of emotional expression on the face, and he has tremors, and there is slowness of gait. So what disorder we are talking about, and then where will be the lesion? What disorder we are talking about, and where will be the lesion? Okay, I'm waiting for your answer. Okay, some of you are thinking Parkinson's. Can it be something else, or is it only Parkinson you're thinking of? What are the features here that are suggestive of Parkinson's? What are the features that here suggestive of Parkinson's? Okay, we'll come to the site of lesion later, but first point, what are the features that are suggestive of Parkinson's? Okay, so Parkinson's disease comes under which neurological disorder? Parkinson's disease comes under what you call as akinetic rigid syndromes. Akinetic rigid syndromes. Okay, now akinetic rigid syndromes, the prototype example of that is Parkinson's disease, but you have other conditions. Broadly, you can classify them as Parkinson's disease and Parkinson plus syndromes. Parkinson plus syndromes or atypical Parkinsonism. Okay, Parkinson plus syndrome and atypical Parkinsonism. Now, Parkinson's disease is a prototype example. The difference between these two, Parkinson's disease and Parkinson plus syndrome, is Parkinson plus syndrome patients have something plus. In addition to Parkinson's typical features, they have additional features like additional neurological deficits and all. That is what you call as Parkinson plus syndrome. So, in Parkinson's disease, the minimum thing that you will see is akinesis or bradykinesia. That is one of the standard component. So bradykinesia means slowness of the movements. Then there should be rigidity. And in addition to rigidity, what sets Parkinson's disease apart from the other Parkinson plus syndromes or atypical Parkinsonism is tremors. So you don't generally see tremors in patients with the Parkinson plus syndromes. It is rare, right? You have to remember, tremors are rare. Tremors are rare. If they are there also, they are not very typical. And second thing is, they have additional neurodeficits. That is why we call them as Parkinson plus syndromes. They have additional neuro deficits. Okay. So in this case, the patient has features of bradykinesia, right? So which symptom that is mentioned in the question is suggestive of bradykinesia? Tell me. Which symptom here is suggestive of bradykinesia? Okay, so these things are essential components for the diagnosis of Parkinson's disease. There should be bradykinesia, rigidity and tremors, 3 components. You can now call it as a triad of Parkinson's disease. 3 should be there to call it as Parkinson's disease. Okay, now bradykinesia, slowness of movements. Which of his complaints are related to slowness of movements? Okay, is that the only complaint which can be attributed to bradykinesia? Yes, his gait is slowed, I agreed. So it is because of the bradykinesia. Any other complaint can be attributed to bradykinesia? Why he is having expressionless faces? So when you talk about Parkinson, we say that they have this expressionless faces, right? You can call it as mask-like face. You know why they have mask-like face? It is also a result of bradykinesia. So it is not that a patient with Parkinson's disease is emotionally blunted and they have no emotions. They have emotions. Okay, in fact, they are emotionally labile. But when you tell them an exciting news, like if it is your friend's dad or someone, and you tell them that you cracked the NEET PG with a single-digit rank, for them to react to that emotional news, it is going to be like very slow. Their facial expression comes out very slow. So by the time you tell them, you would have moved on to your next news, realizing that okay, this fellow is not giving any expression, and you talk the next topic. Then the expression arrives on their face. So there is mismatch between receiving the information and responding to that in the form of expression, because expressions are also slowed down. So bradykinesia is the reason for their reduced expression, and this can also be called as hypomemia. Okay, then so this patient's history is very typical. He has reduced expression, which is because of bradykinesia. Then he has tremors. Important things you need to know about tremors is, one is rest tremors. Now let me ask you a question. The tremors in case of Parkinson's disease are going to be symmetric or asymmetrical? See, they have this typical pill rolling tremors, right? Whether the tremors will be symmetric, both the sides equally affected, or one side more affected than other. Vikas Sharma, they are not unable to express emotions. They do express, but we don't notice because the expression comes later. We give a news. It's like, you know, like when you crack a joke, people behave like tube lights and they laugh later. Something similar to that is happening with them because their expression, the facial movements happen later. Yes, so you have to remember that the tremors of the typical Parkinson's disease is usually asymmetrical, and this is a very important point for you when you have a real patient and you need to make a diagnosis of Parkinson's disease. If you encounter that the tremor is very symmetrical, it is unlikely to be Parkinson's disease. It may be drug induced Parkinsonism or one of those Parkinson plus syndrome with rare tremor as a feature, but it is not likely to be Parkinson's disease. The asymmetry remains prevalent almost till patient dies, because usually the degenerative changes in the basal ganglia happen or starts in one side of the brain, and then later on the other side of the brain gets involved. So whichever side got affected first will always be leading ahead. So the tremors in that side which started first will be much more marked in comparison to the other side which started later. So this disparity continues because it's a neurodegenerative disorder, it's a progressive disorder. So if I get the tremors in my right hand first, then by the time my left hand gets tremors, my right hand would have progressed. As my left hand tremors increase, my right hand would have increased even more. Okay. So asymmetry of the tremors and the slowness of gait. Okay. How do you describe the gait of Parkinson's disease patients? How do you describe the gait? You call it as festinant gait, right? You call it a festinant gait. Why do you call it as festinant gait? Okay, see, the Parkinson's disease gait is a combination of various features. One is bradykinesia is contributing. Bradykinesia is making their gait slow. Okay, they have postural instability because of the autonomic nervous system involvement. So that is also contributing to their gait. But equally, I said we call this as akinetic rigid syndrome, right? So the rigidity is also one of the contributor for the gait. Okay, so when patients of Parkinson's disease develop rigidity, the rigidity in Parkinson's disease predominantly affects the axial as well as extraaxial muscles. When I say axial muscles, that means I'm talking about the muscles of the trunk, your chest, abdomen, and your back muscles of the trunk. And the axial means your extraaxial means your limb muscles, and axial means your muscles of the core of the body. It affects both. It affects axial plus extra axial. So that is why when you examine the hand, you get that cogwheel rigidity, because the extraaxial skeletal musculature is affected, and because the axial is affected, the axial involvement is differential in the sense anterior part of the body muscles are more affected than the posterior. So when I have anterior muscles involved, rigid, that means increased tone, so they are more contractile, and my posterior muscles are less contractile. What will happen to my posture? I will start stooping forward, right? I will start stooping forward. So that they generally, because of this axial involvement, where anterior group of muscles are more affected than posterior, they have this stooped forward posture. So when you stoop forward, what happened to the center of gravity? The center of gravity gets shifted forward, right? So you have a tendency to fall forward. So when these Parkinson's disease patients are walking, they're taking short steps, but as they keep walking, right, they keep accelerating their steps so as to prevent falling. This is the typical Parkinson's disease gait. They have very slow, they have difficulty in initiation of the steps, and because of this stooped forward posture, they try to accelerate faster so that they can escape falling. This is very typical festinant gait that we see in patients with Parkinson's disease. Okay. Okay. Now, this is a Parkinson's disease, and we all know the site of degeneration is basal ganglia. Basal ganglia is where there is lesion, and what degeneration is happening, or which type of neurons are showing degeneration? It is the dopaminergic neurons. Okay. One more question. In case of Parkinson's disease, the degeneration of dopaminergic neurons is only affecting the basal ganglia or other structures in the brain? Only affecting the basal ganglia or other structures in the brain? So you have to remember the first site where the degenerative changes occur, right? So in patients with Parkinson's disease, the first site of neurodegeneration is not basal ganglia. First site of neurodegeneration is anterior olfactory nuclei. So if the anterior olfactory nuclei is showing degeneration, what will happen to the patient's sense of smell? They will develop hyposmia or anosmia, right? They can develop hyposmia or anosmia. So every time you have a patient with Parkinson's disease, when you ask them the history, even before they start noticing tremors or motor symptoms, they give you that at least for 5 years or 10 years, they had history of loss of smell or decrease in the smell. You have to keep that in mind, right? Okay. So that's about this question. The question is about Parkinson's disease, and the site of degeneration is basal ganglia. We have touched here and there important points for you to remember or connect when you read Parkinson's disease in detail. Now let's move to the next question. Okay, the question is, a patient presented with chest pain radiating to the interscapular area. His blood pressure in the left arm is 180 by 100 and the right arm is 120 by 100. Chest x-ray showed mediastinal widening. What is the diagnosis? What do you think is the diagnosis here? Okay, what is the diagnosis here? Okay, I'm waiting for you guys because this should be relatively straightforward. Do you think it's aortic dissection or esophageal rupture, pulmonary embolism, or foreign body in the trachea? Okay, why do you think it is aortic dissection? Why do you think it is aortic dissection? Can this be a case of coarctation of aorta? See, in this case, there is difference in the right and left arm blood pressure, right? Now, can a normal individual have the difference in the right and left arm blood pressure? If you check my blood pressure in the right arm and left arm simultaneously or in rapid succession, do you think there will be difference? Okay, up to what difference can be considered as normal? Okay, so you have to remember that the inter-arm BP difference, especially I'm talking about systolic BP difference, up to 10 millimeters of mercury can be considered as normal. 10 millimeters of mercury can be considered as normal. Now tell me two examples where you have this difference present between the right and left arms. Okay, so difference more than 10 millimeters of mercury. You can see in conditions like one, aortic dissection, because we are talking about a question which is suggestive of aortic dissection, and the second one is your coarctation of aorta. Okay, now before we address aortic dissection and how do we differentiate between coarctation of aorta and aortic dissection as a cause for interarm difference in the BP, can esophageal rupture present with such a clinical picture? When esophagus ruptures, right, there will be massive bleeding, especially into the mediastinum sometimes, because esophagus ruptures mostly in the lower 1/3. So there will be significant amount of blood loss. So if there is a massive blood loss happening, can it lead to hypertensive values that we are seeing here, or even a well preserved BP values? Probably no, right? When you lose massive amount of blood, you develop hypotension. So if there is esophageal rupture, I would rather expect patient presenting with hypotension rather than hypertension. So this is one option that I can comfortably rule out. Okay, and second thing is, if the esophageal rupture, what you call as Boerhaave syndrome, it can cause mediastinitis, because see, when esophagus ruptures, this is your GE junction, no? Esophagus mostly ruptures in the lower 1/3 of the region, right? When it ruptures, it disturbs the function of the lower esophageal sphincter. So the gastric content can regurgitate and enter into the mediastinum. And you know the gastric content is in acidic pH, right? It is in the pH which is very low, usually 2 or less than 2. So when such a low pH fluid enters the mediastinum, it can cause the pericarditis, mediastinitis, even myocarditis. So that is sometimes the reason for death after Boerhaave syndrome. So when the pericardium is inflamed, the myocardium is inflamed, you don't expect them to come with hypertension, rather they will come with hypotension. So esophageal rupture is not going to present with these values for sure. Okay, then pulmonary embolism. Will it come with interarm difference in BP? That is the second question. But will they come with any elevated BP reading? If the pulmonary embolism, the volume of embolus is significant enough, that would rather cause patient presenting with hypotension, right? Why pulmonary embolism would present with hypotension? When pulmonary embolism occurs, right, what is it? I am just drawing you a right ventricle and right atrium. So blood comes to the right atrium from your inferior vena cava and superior vena cava, and the blood makes its way into the right ventricle. From the right ventricle, blood is supposed to go to lungs, right? Your lungs, through pulmonary artery. Now, if there is a clot occluding the pulmonary artery here, then the amount of blood that is reaching the lungs is going to be reduced, right? Because the clot is acting as a hindrance or obstruction. So if the amount of blood coming to the lungs is decreased, then what will happen to the amount of blood returning to the left atrium? The blood that comes to the left atrium is the blood that came to lungs, right? So if this is your left atrium, the amount of blood flowing to the left atrium is going to be decreased. So the amount of blood coming to left ventricle will also be decreased, and thus the amount of blood coming out into the aorta will also be decreased. So anytime you have a significant pulmonary embolism, the cardiac output gets decreased. So that will lead to hypotension, and whenever you have hypotension in a patient with pulmonary embolism, we call it as massive pulmonary embolism. Massive pulmonary embolism. At least we can say that if there is pulmonary embolism, you don't expect them to come with hypertensive values. So this is also an unlikely situation. Then comes the question of interarm difference. Pulmonary circulation has nothing to do with systemic circulation, except that the cardiac output is dependent on the right ventricular output. So why will the patient present with interarm difference? So this can also be ruled out. Now, foreign body in trachea, unlikely to cause an interarm difference, right? So we are left with only aortic dissection. Now, what makes me tell that this is aortic dissection and not the coarctation of aorta is, in patients with coarctation of aorta, you don't see mediastinal widening, right? You don't see mediastinal widening because the aorta above the valve, there is supravalvular aortic stenosis. The aorta is constricted, it's not widened. So why would you see mediastinal widening? Here they mentioned that mediastinal widening is there. So that means probably aorta is dissected. So dissection of aorta becomes our right option here. Okay. Now tell me why in case of coarctation of aorta, blood pressure is high in the right arm and is relatively low in the left arm. Pukar Adhikari, absolutely right. So the mediastinal widening is the potential clue. So even if I mention as option of the coarctation of aorta in the question, you should still go ahead with aortic dissection because the mediastinal widening is being mentioned. Okay. So tell me why in case of coarctation of aorta, the BP in one arm, particularly right arm, is more than the left arm. So in patients with coarctation of aorta, what happens is the coarctation is supravalvular. So somewhere here you have a aortic valve and the coarctation or constriction is in the supravalvular segment. The constriction happens in such a way that the jet of the blood gets more directed towards what you call as innominate artery or the brachiocephalic artery on the right side, innominate artery, this. So because of this, the blood flow to the right side of the limb increases and the blood flow to the left side of the limb decreases, or left upper limb decreases. That is why in case of coarctation of aorta, you have right arm BP more than left arm BP. Right arm BP more than left arm BP. Okay, so that's about that question. This is one of the image of a patient whose X-ray showed. This is again a case which presented with similar clinical presentation. Later it developed significant hypotension, and when X-ray was done, it shows significant gross mediastinal widening. This is a typical X-ray of a patient with aortic dissection. So sometimes they might give you image, right? Again, X-ray image can help you to pick up coarctation of aorta or the dissection of aorta looking at the X-ray. Okay, now this was the next question. This is pretty straightforward. I think all of you would have answered this. They have given you a image of a murmur tracing, and all students said that it looked like a pansystolic murmur. This is how it looked like. It looked like a pansystolic murmur. So what condition can cause pansystolic murmur is the question. Pretty straightforward question, right? Mitral regurgitation, aortic stenosis, pulmonic regurgitation, tricuspid stenosis. आपका फैन, yeah, I will share you the details. Okay, so which murmur is going to be pansystolic? What is the murmur of tricuspid stenosis? Because we had discussed one question on this in the PW sprint session, and also the similar question had appeared in the NEET PG also, right? The question was a patient of someone presented with a diastolic murmur and he had a prominent A wave on the JVP, right? I think a very similar question appeared on the NEET PG exam, right? Okay, so what kind of murmur we see? In case of tricuspid stenosis as well as mitral stenosis, the murmur that we see is mid-diastolic murmur. Mid-diastolic murmur, right? Okay, then in case of pulmonic regurgitation, what murmur we are going to see? Pulmonic regurgitation, aortic regurgitation, you are going to get the same kind of murmur. So what murmur we see? So in case of pulmonic regurgitation, you are again going to get a diastolic murmur, which is most likely going to be an early diastolic murmur. Same murmur you might hear in patients with aortic regurgitation, right? Okay. In aortic stenosis, what kind of murmur you get? You get a systolic murmur, I agree, right? So let me just draw a simple image and then we will discuss. So this is our heart. This is our left atrium. This is our right atrium. From the right ventricle, we have pulmonic artery going up, and from the left ventricle, we have the aorta going up. So this is my aorta, left ventricle, right ventricle. Here I have a tricuspid valve. Here I have a pulmonic valve. Here I have aortic valve. Okay. Now, if I have a aortic valve stenosis, the murmur is going to be systolic, because when the left ventricle during systole tries to eject the blood into the aorta, the resistance is encountered. So we'll have a systolic murmur, but the murmur is not going to be pansystolic. The reason for that is the first part of the systole is isovolumetric contraction, where your aortic valve is closed, your mitral valve is closed, and left ventricle is just contracting to eject the blood into the aorta. But it is just contracting, the volume is not changing because the valves are closed. So during this period of systole, you don't hear any murmur. So in case of aortic stenosis, you hear an S1, then there is a phase of isovolumetric contraction where there is no murmur, then the valves open. Once the valves open, the blood from the LV starts moving to aorta, and that creates a turbulence and that generates a murmur. So a murmur of aortic stenosis will start with the phase of ejection. After the isovolumetric contraction phase, you enter into phase of ejection. That is where the murmur begins. So you start with a ejection click and then you get a murmur which is generally diamond shaped. You describe it as crescendo, decrescendo murmur, and then you get your S2. So the murmur of aortic stenosis is systolic, but it is not the pansystolic. It is the ejection systolic. Ejection systolic. But the murmur of mitral regurgitation is pansystolic. Why is it going to be pansystolic? What is the problem in mitral regurgitation? In patients with mitral regurgitation, the problem happens in the ventricular systole. So you have this mitral valve here. Now when the left ventricle is in systole, it is contracting. There should be one direction of flow of blood, right? Because the mitral valve is supposed to be closed during the left ventricular systole and the blood should be going into the aorta. Aortic valve is expected to be open. But in the regurgitation, mitral regurgitation, unfortunately, the left atria is not protected by a closed mitral valve. The valve fails to close. So the blood also moves into the left atrium. And because the valve did not close at all properly, right from the isovolumetric contraction stage itself, right? You have this S1, this is your S2. Right from the isovolumetric contraction stage itself, the blood starts moving into the left atrium, and that is why you get a pansystolic murmur. The movement of blood started happening across the aortic valve in aortic stenosis once the valve opened. So during isovolumetric contraction, there was no movement, so that's why you didn't have a murmur. But in case of the mitral regurgitation, the moment left ventricle gets into a isovolumetric contraction, blood may not go to the aorta because aortic valve is closed, but it starts getting into the left atrium, and that is why the murmur is going to be pansystolic. So the murmur of mitral regurgitation would be pansystolic, and that's our correct answer. Okay, so this is what they had given as an image, and the answer was very clear. Now please remember, as the exam gets more heated up, right, in the subsequent years, you might start getting the audio clips of murmurs, so start start auscultating the patients, so that even if they give you an audio clip, you should be able to identify. And instead of simply giving a graph, they might give you a phonocardiogram. You should be able to identify even based on that. Okay, now let's move to the next question. A middle-aged woman with bronchial asthma and history of thyroid disorders now developed fever, tachycardia, BP of 180-110, and atrial fibrillation was detected on ECG. What is the next step in the management? This is a very tricky as well as a controversial question. Okay, so my answer may be a little different from the answer given by other faculty members or my dear friends, but we will discuss why I think my answer is probably right. So a middle-aged woman, bronchial asthma, she is having a history of thyroid disorder. Now she has developed fever, tachycardia, BP is 180/110, and she is having atrial fibrillation on ECG. Pukar Adhikari, the problem here is the patient is having bronchial asthma. She's having bronchial asthma. So can we give the beta blockers? That's the main problem, right? Can we give beta blockers if the patient is having that too, non-selective beta blockers? Okay, so I think all of us can agree that this story is of a patient with thyroid storm. She is a known case of thyroid disorder. They have not mentioned whether it was a known case of hypo or hyper or whatever. They've told she has thyroid. Now that she has got a febrile response, tachycardia, hypertension and atrial fibrillation, it makes me think that this is a case of thyroid storm. So it's a case of hyperthyroidism or thyrotoxicosis. Now because she is a known case of bronchial asthma, we cannot give beta blockers, right? So beta blockers are option as out. Can we consider esmolol? See, even the selective beta blockers are not considered absolutely safe in patients with bronchial asthma, and they are better avoided. Okay. Now, can we give diltiazem and propylthiouracil? The question here is, what do you want to address? You want to address thyroid storm as an entity, or you want to address her atrial fibrillation? Okay. So let me reframe the question. In a patient with thyrotoxicosis, should we just give me a second, guys. In a patient with thyrotoxicosis, should we treat the hyperthyroidism in a patient with the thyrotoxicosis and atrial fibrillation, should we treat the atrial fibrillation with antiarrhythmic drugs or stick to the treatment of thyrotoxicosis or hyperthyroidism itself? Okay, so let me make a statement for you. In a patient with hyperthyroidism or thyrotoxicosis of whatever etiology, if they are associated with atrial fibrillation, you have to remember that more than 50% of atrial fibrillation revert to sinus rhythm once euthyroid status is achieved. Euthyroid status is achieved. Okay, so it is not a priority for us to convert the atrial fibrillation into sinus rhythm by giving antiarrhythmics. First priority would be to treat them to achieve a euthyroid status. Okay, so that is clear. Atrial fibrillation is not our priority. We don't need to give them antiarrhythmic drugs. Okay. Now, if I let it be in atrial fibrillation, the thyroid gland is going to take some time to get corrected if I give them antithyroid drugs. Till that time, it can cause problem, right? What problem it can cause? The main problem it would cause is probably embolism, right? Should we give anticoagulation? Yes, anticoagulation should be given. Anticoagulation should be given, but not for all patients. You have to make a decision based on CHA2, DS2, VASC score, right? So based on that score, you decide whether the patient requires anticoagulation or not, aspirin alone or something else, based on the CHA2, DS2, VASC score. Not for all patients. If the VASC score says that there is no need for anticoagulation, no need for anticoagulation. VASC score says that there is need for anticoagulation, there is need for anticoagulation. But rhythm per se need not be attended to as priority. First, try to achieve the euthyroid state. If you achieve the euthyroid state, after that rhythm still remains like more than 50%, it is going to revert. The patients who have the rhythm remaining, only them we will need to think of doing the rhythm correction, right? So in this case, the atrial fibrillation is not my priority. Treating the thyroid storm is a priority. Then comes the question, right? What is the drug of choice for treating the thyroid storm? Okay, so you have this carbimazole, methimazole, and propylthiouracil. Between these three drugs, which one will you give if the patient is going through thyroid storm? See, if I had given you the option of carbimazole and methimazole, now some of you are jumping to say propylthiouracil, propylthiouracil. But if the options also included carbimazole and methimazole, what would be the answer? Okay, Pukaradhikari, absolutely right. Why propylthiouracil is the answer? No, propylthiouracil should be the answer. So you have to remember that when you talk about thyroid storm, it's an emergency, right? You have to bring down the thyroid hormone levels and its efficacy as down as possible. And two drugs are very important for a management of thyroid storm, right? One is your beta blockers, and preferably when you talk about beta blockers, it is going to be propranolol, not your esmolol or any other beta blockers, propranolol and propylthiouracil. The reason for that is both propranolol as well as propylthiouracil inhibit, both of them inhibit peripheral conversion. In addition to, they inhibit peripheral conversion of T4 to T3. Which one is more potent? T4 is more potent or T3 is more potent? Right. So now you got the gist of it. T3 is more potent. So I don't want good amount of T3 in circulation, right? If there is like little larger amount of T4 in circulation, chalega, because it is not as potent as T3. And because both propranolol and propylthiouracil inhibit this conversion, they are considered as the initial preferred agents. And beta blocker gives you a additional benefit that it will also address the symptoms like BP and the tachycardia, atrial fibrillation. It will slow down the rate. So I would have given propranolol if there was no bronchial asthma, but because there is bronchial asthma, I am not giving it. But the priority drug now would be propylthiouracil. Okay, carbimazole and methimazole you will introduce later once the patient is out of the thyroid storm. Carbimazole and methimazole are more potent, more efficacious drugs. So I would definitely give those drugs, but later. Right now, I will give propylthiouracil. So for this, my choice of answer is propylthiouracil. That's the correct answer here. Okay. Now, moving to next question. What is the aim of TPA in the management of myocardial infarction? Right. I mean, this is a very straightforward question. I'm not going to waste too much of time. So it is obviously we know fibrinolysis, right? We call these agents as fibrinolytic agents. So it was a no-brainer. All of you would have given the right answer. Antiplatelet agents are different, right? And the thrombin inhibitors are different. So TPA is a fibrinolytic agent. So it's like more of a pharmacology question. Okay, now coming to this question, this was also pretty straightforward. See, diltiazem you can give for the rate control, but as I've already told you, right, most of the atrial fibrillations that you see, which is because of the thyroid abnormalities, they revert to sinus rhythm if you achieve a euthyroid status. And if you give diltiazem, what you will achieve? You will achieve slowness of the atrial fibrillation. Okay, maybe a little decrease in the BP and little decrease in the tachycardia, but the thyroid storm is much more than that. So if you address the root cause, that will solve the problem. By merely slowing down the heart rate and BP to some extent, it may not suffice, right? You have to address it from the root cause itself. That's why I would say PTU would be the choice. If the same scenario, but it is not a case of thyroid disorder, right? Someone presenting with an accelerated hypertension and atrial fibrillation, but not a case of thyroid disorder, not suggestive of thyroid storm, and there is a contraindication for beta blockers, I would have gone with diltiazem, because there the atrial fibrillation, rhythm correction and rate control become priority. Okay. Now, this is the question. A patient was on treatment for hypertension and developed hyperkalemia. ECG is shown. Which drug can cause this side effect? Even if the ECG is not given, you know what drug would cause this side effect, right? So what do we see in the ECG? We see tall tented or tall peaked T waves. I think the ECG was very similar in the main exam. Anyway, the essence is very same. We had tall tented or peaked T waves. So it is suggestive of hyperkalemia. Which antihypertensive can cause hyperkalemia? Okay, let us list. Hydrochlorothiazide was one of the option, metoprolol and spironolactone. Which drug will cause hyperkalemia? Okay, what electrolyte abnormality hydrochlorothiazide or thiazides can cause? Do thiazoids cause hyperkalemia? Right, yeah, the drug we are talking about can also cause gynecomastia. Like, what is the side effect of thiazides? Electrolyte abnormality associated with thiazides. Okay, so thiazides can cause hyponatremia. Thiazides can cause hyponatremia. In fact, it is the most common cause for hyponatremia in OPD practice. In outpatients or OPD patients, it is the most common cause for hyponatremia. Then you might ask me, sir, what is the most common cause for hyponatremia in inpatients? Most common cause for hyponatremia in inpatients is SIADH. In patients is SIADH. So hospitalized patients, it is SIADH. In outpatients, it is thiazides. So a lot of hypertensive heart failure patients will be getting thiazides as an add-on to their another antihypertensive measures, and that can lead to development of hyponatremia. So when you see them in the OPD, they will have this sodium report of 130, 131, 132, less than normal, but mild hyponatremia, not very symptomatic. So that typical picture is because of thiazides. But when you see a patient hospitalized because of hyponatremia with a sodium values of less than 125, 120, severely symptomatic of it, it is most likely because of SIADH. Okay. Metoprolol has mostly nothing to do with electrolytes, so that is an option we can comfortably rule out. Pukaradikari, yes, absolutely right. So spironolactone is the one acting through the mineralocorticoid receptors, can be a reason for hyperkalemia, right? So you often list it under potassium sparing diuretic. So this is the one thing which is known to cause hyperkalemia. Another side effect you need to remember is, as someone has already mentioned, that it can cause gynecomastia, right? So this question is also pretty straightforward. The right answer is spironolactone. I'm not discussing more on that. Now moving to the next question. A young man with history of physical fight presented in the emergency with pain in the neck. Imaging revealed penetration of bony fragments into lateral aspect of dorsal column. Which of the following will be affected? So the dorsal column, they are told that lateral aspect, that basically means that it is a unilateral injury to the spinal cord, unilateral injury to the dorsal column. Now, which of the following sensation will be lost? Proprioception in the ipsilateral arm, proprioception in the contralateral arm, weakness of the distal muscles in the ipsilateral arm, or proprioception in the ipsilateral thigh. What is the right answer? And if you have any discrepancy in the options, so please let me know how was the options framed for this question. Did options have the exact similar appearance, or there were any word play that we have missed? See, one thing is very clear, that they have told that there is injury to the dorsal column. There is injury to the dorsal column. Now, what are the sensations which are carried by the dorsal column, or what is its function? Is it part of the motor tract? Obviously no, right? Motor tract is pyramidal tract. Is it part of the extrapyramidal tract? No. So mostly you will not have any motor symptoms per se. So it is part of our sensory tracts or the ascending tracts. Now what are the sensations carried by the dorsal column? Number one is fine touch, and second one is proprioception. Okay. Now, the main important thing when you study about the tracts, ascending and descending tracts, is to understand where the decussate. That will give you an idea when the tract is transected, what will happen in terms of clinical features. Right, fine touch and proprioception. Where is the decussation of this tract happening? See, this much is clear, right? We are talking about the dorsal column, which is an ascending pathway, and it is carrying fine touch and proprioception. Then you have these other ascending tracts like the anterolateral system, having the lateral spinothalamic tract and the anterior spinothalamic tract. They are concerned with the other sensations. The descending tracts, you have pyramidal and extrapyramidal. Pyramidal is what you call as a motor tract. Right. Okay. So there are some tracts which decussate within one or two spinal segments. They decussate to the opposite side. If such a segment is transected somewhere up in the pathway, then it will cause a contralateral injury. But then there are some tracts which will ascend quite far and then decussate quite higher up in the order. Now, if you transect that, then probably you will have a ipsilateral involvement. So in case of the dorsal column, where is the bifurcation or the transmigration is happening? Decussation in case of the dorsal column. So this is a dorsal column. As you can see from the image, right, it ascends up quite a distance, and the decussation usually happens at the level of medulla. So once you transect here, let me say that you are cutting the dorsal column here. Now the sensation carried from the ipsilateral side is not reaching the brain, or the sensation carried from the opposite side is not reaching the brain? Tell me now. See, if there is another tract, ascending tract, which decussates as soon as it enters the spinal cord and then ascends up, if I cut that tract here, then the sensation which are carried from the opposite side is going to get affected, contralateral side. But in case of the dorsal column, it ascends straight up, right? The decussation happens at the level of medulla. So if I cut the dorsal column any side below the level of medulla, then the ipsilateral side, the sensation will be affected, right? Okay, so they have things that we can comfortably rule out is the weakness of distal muscles, because we are not talking about the motor tract here anymore, right? Then proprioception in the contralateral arm is also ruled out, right? Because it is decussating at the medulla, right? So remember this point, decussation at medulla. Now because I have not given the level of the lesion, okay, they have mentioned the neck, right? Okay, so in that case it is very straightforward that it is the proprioception in the ipsilateral arm which is going to get affected. Proprioception in the ipsilateral arm which is going to get affected, and that becomes our correct answer. So for all the tracts, ascending and descending tracts, please remember you are thinking about the level of decussation to understand whether ipsilateral or contralateral involvement happens. Okay, now the next question is, please help me with this question, because I'm not very sure if the question exactly appeared like this, because it doesn't make full sense to me. A patient with hyperkalemia refractory to other modalities was treated with hemodialysis, but long-term HD can cause nausea, dizziness, cramps, headache, CNS disturbance, and even convulsions. How will you treat a patient presenting with such a feature? Okay, this question literally doesn't make sense to me. So if there is any word play or any placement of words or sentences are not correct, let me know, because what I have spoken to students and what I've understood is most of them were telling that this is a description of dialysis disequilibrium syndrome. Disequilibrium syndrome. Okay, anybody has any idea about what is dialysis disequilibrium syndrome is? Any idea about the dialysis disequilibrium syndrome? What is it? Okay, so how many of you think whatever I have written here is very typical of dialysis disequilibrium syndrome? Okay, let me dissect it statement by statement. Patient with hyperkalemia refractory to other modalities of treatment was treated with hemodialysis. Okay, logical. Hyperkalemia is a medical emergency, but most cases hyperkalemia you treat with anti-hyperkalemia measures. You give dextrose with insulin, because insulin causes shift of extracellular compartment potassium into the intracellular compartment intercellular compartment. So we can give dextrose with insulin. To stabilize the myocardium, you can give calcium gluconate or calcium carbonate infusions. Then you can give potassium binding regins like calcium polystyrenate, so that the K bind is what you call, that inhibits the absorption of potassium from the gut. And you can give the acetylene nebulization. These are the standard modalities followed for management of hyperkalemia. If this does not help, patient continues to have alarming levels of potassium or significant ECG changes, then there is a risk of cardiac arrest. So you might have to take the patient for dialysis. Okay. Then long-term dialysis, yes, it is associated with various complications. It definitely includes nausea, dizziness, cramps are very common. Then patients with dialysis do experience frequent headache episodes. Then the CNS disturbance and convulsions, they can happen as a long-term complication, and there are various reasons. It could be because of aluminium toxicity. Previously, the dialysate used to have aluminium as one of its component, and many patients develop aluminium toxicity. Nowadays, we are not using aluminium in the dialysate fluid, so that prevalence has come down. So the dialysis disequilibrium syndrome can occur in the long run, but most of the patients, like I would say 99% of the patients who develop or present with dialysis disequilibrium syndrome, they present within first 2 sessions of dialysis. Okay, so what is this dialysis disequilibrium syndrome? It is a condition where patients develop the cerebral edema following dialysis. Why is he developing cerebral edema following dialysis? It's not very well understood, but basically what we know is when the patient goes through dialysis, before the dialysis for several months or years, he is in a hyperuremic state, right? So he's having the uremia, his urea levels are high, his electrolytes like the potassium may be on the higher side. When we subject them for dialysis, his brain is already accustomed with this hypertonic environment or elevated urea levels. When we subject the dialysis and reduce the urea levels, now we are challenging the brain with another osmotic shift. So this osmotic shift is the one which is responsible for development of cerebral edema. So obviously that would happen in first few sessions of dialysis. After that, whatever is the change in the blood parameters, the brain gets accustomed to it. So the chances of developing dialysis disequilibrium syndrome later comes down. If they're mentioning that long-term HD is associated with these features, it is less likely to be dialysis disequilibrium syndrome, and it's mostly a manifestation of the aluminum toxicity or other complications associated with dialysis. Okay, so at least if the question was dialysis disequilibrium syndrome itself and they had not used this term long-term and all, and they had mentioned that it is first or second session of dialysis, then I would be very sure that this is disequilibrium syndrome, and that disequilibrium syndrome can be to some extent managed or prevented by giving mannitol infusion. Okay, how can we help by giving mannitol infusion? Because it is the osmotic shift. Urea is an osmotically active substance in the patient's blood. You took it out by dialysis, and that is creating the osmotic shift responsible for cerebral edema. So by adding some osmotically active substances into the patient's blood, which is not as toxic as urea, you can reduce the impact of this dialysis disequilibrium. So the answer here becomes mannitol infusion. Okay, so I hope the point is clear. What are we doing by giving mannitol infusion? We are taking out urea, which is osmotically active, that is responsible for the cerebral edema. We are adding something which is osmotically active, right? As simple as that. Okay, now this is the next question. An elderly male patient with prior MI and ventricular tachyarrhythmia, treated for 4 years with medications. He has dry cough and dyspnea, fatigue for 3 to 4 months, and he also developed hypothyroidism, the drug that can be responsible. Okay, is it amiodarone, clopidogrel, simvastatin, or carvedilol? See, what are the findings we are seeing here? It's a case of MI. So for MI, what are the drugs we would be giving? We would definitely be giving antiplatelets, undoubtedly. Right? Will we be giving beta blockers? Yes, we will be giving beta blockers. We might be considering giving AC inhibitors to these patients. Right? Okay. Now, in addition to that, he had an episode of ventricular tachycardia. So for management of ventricular tachycardia risk, we would have started him on antiarrhythmics. Right now, we generally give a broad spectrum antiarrhythmic, which is amiodarone, right? Whether supraventricular arrhythmia or ventricular arrhythmia, I don't need to scratch my head comfortably, I can give amiodarone. So mostly the patient was getting amiodarone for that. Okay, now he has presented with dry cough, dyspnea, and fatigue for 3 to 4 months. It is a long duration, right? 3 to 4 months, and the cough is non-productive. Patient is dyspneic. It's not merely that he's experiencing cough, he's becoming breathless. So that means there is some sinister or major issue with the lung. It is not merely a respiratory infection, right? So what it could be, it is mostly suggestive of interstitial lung disease, or at least we can start thinking in that direction with the information we have. So among the drugs mentioned, which one can cause interstitial lung disease? And he has also developed hypothyroidism. So which drug is known to cause hypothyroidism? Okay, can amiodarone cause hypothyroidism? Can amiodarone cause hypothyroidism? Can amiodarone cause hyperthyroidism? Yes, right. Amiodarone can cause both. It can cause both. It can cause hypothyroidism as well as hyperthyroidism, right? Amiodarone induced thyrotoxicosis type 1 and type 2. We know 2 types of amiodarone induced thyrotoxicosis. It can also cause hypothyroidism, and amiodarone is implicated in causing interstitial lung disease. Right now it is a leading cause for interstitial lung disease. It's a leading cause for interstitial lung disease. Okay, can anybody tell me what are the other drugs known to cause ILD? Drugs known to cause interstitial lung disease? Yes, it causes both hypo as well as hyperthyroidism. Okay, tell me one antibiotic which is known to cause interstitial lung disease, which generally you prescribe for a longer duration of time, not like 5 days, 6 days. You prescribe it for a relatively long period and it is known to cause interstitial lung disease. Yes, the drugs used for the treatment of malignancies or the cytotoxic agents, yes, they are known to cause. Busulfan, bleomycin, yes. Tell me an antibiotic which is known to cause interstitial lung disease. You use it for the treatment of methotrexate, yes, peritoneal fibrosis as well as the interstitial lung disease. Okay, you use it for treatment of urinary tract infection. Nitrofurantoin is a known cause for interstitial lung disease. Okay, from B say busulfan, bleomycin. Okay, can immunosuppressant agents cause, like methotrexate, cyclophosphamide, can they cause interstitial lung disease? Methotrexate, right? Lot of immunosuppressants themselves can cause interstitial lung disease. So that includes methotrexate, azathioprine, right? These are also known to cause. And amiodarone. Right now, amiodarone is the commonest cause for drug-induced interstitial lung disease. Right now, it is the most common cause for drug-induced ILD. The reason for that is, see, when you talk about busulfan, bleomycin, used very rarely when you have an indication for it. Then methotrexate almost not used. Methotrexate and azathioprine, they cause interstitial lung disease, but relatively less common or rare to cause. Not in every patient that we prescribe it and ends up causing. Nitrofurantoin, only selected set of patients you might give it for a month or so, not like you will give it for 6 months, 1 year and all. But amiodarone in patients with arrhythmias or where it is indicated, we generally give it for prolonged period of time, especially atrial fibrillation patients. So there is usually prolonged exposure sufficient enough to induce interstitial lung disease. Okay, so this is actually a HRCT of a patient who was on amiodarone and he has developed interstitial lung disease, right? Can anybody tell me what kind of interstitial lung disease you are seeing here? NSIP pattern or it is the UIP pattern? This is an amiodarone induced ILD. Is it NSIP pattern or UIP pattern? Okay. See, when you see here, like every time you talk about an HRCT image suggestive of interstitial lung disease, we try to classify that into either UIP or NSIP, right? There are two patterns and we know that UIP is really bad and NSIP is okay because UIP is associated with very poor prognosis. Less than 50% 5-year survival, and NSIP is associated with relatively better prognosis, more than 80% 5-year survival. Okay, so the identifying points is in UIP you will see extensive honeycombing changes or honeycomb changes. In NSIP you will see ground glass opacities. And the second point I want you to remember is in NSIP there is more diffuse involvement of the lung. In case of UIP there is subpleural predominance. So when you see this UIP pattern, no, this is a pleural line. So in this subpleural area, this is where you will be seeing extensive fibrotic changes. In the NSIP pattern, it is more diffuse, right? It is not restricted to the subpleural region. And what we see here is ground glass opacity, is not honeycomb changes, right? Does it look like honeycomb? No, right? So this is typical NSIP pattern that we are seeing. And this was from a patient with amiodarone induced interstitial lung disease. Okay, so clopidogrel has nothing to do with thyroid function. It has nothing to do with interstitial lung disease. So option ruled out. Simvastatin. Okay, what is the common side effect of statins? Statins mostly cause myopathy, right? A simple myopathy or immune-mediated necrotizing myositis, more severe and aggressive form, where there are antibodies formed against HMG-CoA reductase, right? Anti-HMG CoA reductase antibodies is what you get if it is immune-mediated necrotizing myositis. If it is a simple myopathy, no antibodies, you can reduce the dose of the statins and still continue. But if it is immune-mediated necrotizing myositis, you cannot afford to expose the patient again to statins. But it has nothing to do with interstitial lung disease, nothing to do with hypothyroidism or per se. Okay, carvedilol or beta blockers, might cause patients' hypothyroid symptoms to get exacerbated, but beta blockers have no established role in causing the interstitial lung disease at least. Okay, so all this keeping in mind, we can believe that amiodarone is our concern. Yeah, statins can elevate the liver enzymes, right? So amiodarone is the answer. Okay, now let's move to the next question. I think this is pretty straightforward and all of you, I'm sure, have answered it right. So I'm not getting into the details. So there was a patient who was an old man, chronic smoker, presented with pain in the right arm. There is also evidence of ptosis and chest x-ray image was given. Chest x-ray showed a right apical mass. So the story is suggestive of the Horner syndrome and there is a right apical mass. So the answer would have been pretty straightforward that we are dealing with the Pancoast tumor. So I don't even know what other options were there because none of the students were able to recall the other options because it was that straightforward. So that was one of the question. Now the next question is, a patient underwent surgery. His urine osmolarity is 100. Serum sodium is 154. What is the diagnosis and management? This is a really interesting question, or somewhere it might have a little bit of controversy, but this is interesting. Okay, so let me summarize. His urine osmolality is 100. Is it normal? Is it normal to have a urine osmolality of 100? What is the maximum dilution that we can achieve? The maximum dilution that we can achieve. Urine can be concentrated or diluted depending on how much water needs to be reabsorbed at the level of kidney, depending on your serum osmolality, right? So, what is the maximum dilution we can achieve? And what is the maximum concentration we can achieve? The max dilution that we can achieve is less than 100 milliosmoles. So you can have urine as dilute as less than 100 milliosmoles, and the max concentration you can achieve is usually somewhere in the range of 800 to 1200 milliosmoles. So urine can be as concentrated as 1200 milliosmoles or even as dilute as less than 100 milliosmoles. Okay, that's the extreme range. Okay, now in this question, the urine is diluted, right? The urine osmolality is less than 300. That means it is dilute than usual urine. Okay, and you also have evidence of hypernatremia. So what can explain it? Is it diabetes insipidus or something else? Do you expect the sodium levels to be elevated in patients with diabetes insipidus? Okay. So the center of all our issues is serum osmolality. Body tries to maintain the serum osmolality in the range of 285 to 295 milliosmoles per liter. That's our body's goal. It wants to maintain the osmolality in this range, right? Okay, to maintain the osmolality in this range, what are the things which are helping? One is your vasopressin. Vasopressin plays an important role in the regulation of serum osmolality. And the second one is your thirst mechanism. Thirst mechanism. These two have a closely related equations to bring out a normal urine osmolality, okay, or serum osmolality. Now let me tell you a scenario. Scenario number one, the serum osmolality of the patient has increased. Okay, so what does that mean? When the serum osmolality of the patient is increased, it means his serum is more concentrated. So it indicates that there is decreased amount of water there and there is increased amount of solutes, or one of the two. Now how can you correct? Either you have to correct by eliminating the solutes from the plasma, which doesn't happen. There is no mechanism to deal with that. So the osmolality is mainly regulated by managing the water. So if the water is low, that is why the serum osmolality has gone up. You can try to increase the plasma water. How can you try to increase the plasma water? One is, this can stimulate the thirst center to increase the thirst. So if the thirst increases, you will drink more water, and this increased water intake will bring the water levels in the plasma back to normal and serum osmolality is normalized. Second thing is, you can play with the kidneys, the amount of water that is excreted. So when the serum osmolality increases, it stimulates increased production of ADH or vasopressin. So as the name suggests, ADH, antidiuretic hormone. So it will stimulate the kidneys to increase the reabsorption of water. So once the water level of reabsorption increases, urine excretion of water comes down. So you have more concentrated urine going out and more water being reabsorbed to set this water deficit back to normalcy, getting your serum osmolality back to normalcy. So simplest way to remember the relation between serum osmolality and ADH is both of them go in the same direction. If serum osmolality is going up, ADH also goes up. It goes up, goes to the kidney, absorb more water and sets the osmolality back to normalcy. Okay. Now if you have a problem with ADH, the ADH production is not happening, or at the level of kidney there is a receptor problem, that is what we call as diabetes insipidus. So in that case, what is going to happen in patients with diabetes insipidus? There is ADH dysfunction, either because the hormone is low or because it is not able to work at the kidney. Now the net result of this is the ADH is not able to increase the absorption of water. Whenever the serum osmolality is going up, it is not able to absorb, the increased absorption of water is not happening. You lose more water in the urine. So when the ADH dysfunction occurs, there is increased free water loss in the urine. So when there is free water increasing in the urine, what happens to the urine osmolality? Urine osmolality will be very low, right? Because the urine is getting diluted, it decreases. Urine osmolality decreases. So once the urine osmolality decreases and you are losing a lot of free water, the serum osmolality will start going up because the water in the body is getting depleted. But there is a savior for us. The savior is our thirst mechanism. So even if you have a diabetes insipidus, your vasopressin is not working, you're losing a lot of dilute urine, or you're losing a lot of water in the urine, you feel thirsty and you compensate for that, right? So diabetes insipidus has led to polyuria, but this polyuria gets compensated by the action of the thirst mechanism, and thus you have polydipsia. So that is why a typical case of diabetes insipidus has polyuria plus polydipsia. But increased drinking will somehow maintain your serum osmolality back to normalcy. But if the thirst center is also affected, which is there in the hypothalamus, then you have no protection, right? You lose a lot of plain water in urine and your plasma keeps getting concentrated. You're not drinking more to compensate for it. Your plasma keeps getting concentrated and you develop hypernatremia. So in this question, that is exactly what is happening. So urine osmolality is very low. It is suggestive of dilute urine. So I would, looking at this, consider that it is a case of diabetes insipidus. Okay. But this patient's thirst center is affected somewhere. So that is why his sodium is high. If the thirst center was normal, he would have taken in a lot of water through the form of drinking and he would have corrected his serum osmolality. So we are seeing hypernatremia because of thirst center dysfunction. Okay, and in fact it is considered as a deadly combination. So diabetes insipidus patients generally do not have hypernatremia or the serum hyperosmolality because thirst center is a protective mechanism. But if thirst center is affected, patient can get dehydrated to death, and this is what may be happening in this patient if not treated. Okay, the question is, we have to treat. So we have to treat by giving an ADH analog, which is desmopressin. Why we use desmopressin? Because ADH is a very short acting agent. So if you give ADH, you need to give as an infusion. But the desmopressin is more potent and long acting. It is nothing but a derivative of ADH. 9 amino acids, we have made it into 8 amino acids and it has become long acting. So thus it can be given in various forms. You can give desmopressin in the nasal form, subcutaneous, intramuscular, in various forms. So because of that, desmopressin is a drug of choice. But should we give for 2 weeks or should we give permanently? Or option C is, it is dysregulation of osmoreceptors, no treatment required. Well, there is probably dysfunction of the osmoreceptors, but treatment is required. You can't let the patient get too dehydrated and die out of it, right? So between these two, start desmopressin for 2 weeks or desmopressin permanently. Which one will you choose? Will you give it permanently or for 2 weeks? Yeah, so the few points here, Prem Kumar, you're right. So the few points here is, yes, transient diabetes insipidus can happen post-surgery, especially the CNS surgeries, skull-based surgeries or pituitary surgeries. Yes, you're right. The second thing is, if the patient has good access to water during this period, or if his fluid intake is maintained, during this period, then they make a recovery. So here in this case, mostly the treating surgeon has not given adequate IV fluids to maintain the fluid intake, and that might have contributed to hypernatremia evolving. Okay, rather than thinking it as a case of the thirst mechanism being affected. The reason I'm saying this is, if they have to make me think that the thirst center is getting affected or it is damaged, they have to tell me that the surgery was mainly involving a particular part of the brain. They have not told about anything about the surgery, which surgery it was, right? So yes, it is more logical to consider it as a transient DI following a surgery, and dehydration is not a rule, but if it is occurring, probably we're not given adequate fluids. So hydrate him, and among the options, maybe for now you can give him desmopressin for 2 weeks. Okay, after that, if the patient has persistent DI, then you can think of a long-term management with desmopressin. But it is more logical to think of giving desmopressin for 2 weeks because there may be an iatrogenic component to its cause. Okay, but I'm not really sure the question was exactly like this. If the framing of the question was different, please let me know. We can think of the answer according to that. Okay, now let me move to the next question. I think this will be my last question. A patient presented with symptoms suggestive of tuberculosis. Sputum sample was negative for Mycobacterium tuberculosis. They had mentioned a pituitary surgery. Okay, see, even if they have mentioned a pituitary surgery, it can be transient, because when you do a pituitary surgery, the two things can happen. You can transect the pituitary stalk. If you have transected the pituitary stalk, then it's going to be a permanent DI. But merely handling the pituitary gland itself can cause the stalk dysfunction, and that can cause diabetes insipidus. In that case, okay, there will be recovery within 2 to 3 weeks of time. So even in that case, it is more safer to go ahead with the option as the 2 weeks of desmopressin. But if they mention that we had operated on a hypothalamic tumor or a hypothalamic hamartoma, okay, in that case, it is most likely going to be a permanent damage, and I would say the permanent desmopressin therapy. Okay. This is the last question. Patient presented with symptoms suggestive of tuberculosis. Sputum sample was negative for Mycobacterium tuberculosis. Chest X-ray findings are suggestive of TB. What should be the next step in the management? This is a very simple question. You would have also learned it from the PSM. For all tuberculosis related questions, please address it according to RNTCP protocols, right? According to RNTCP protocols. So I'm giving you one important flow chart. You have to memorize this because you will get a lot of questions related to it. Just give me a second, guys. Okay, I think it is little tilted, but you can probably understand by looking at it. So when you have a patient presenting with suspected tuberculosis, we call it as presumptive tuberculosis. When they have more than 2 weeks of cough and expectoration, often associated with weight loss or hemoptysis, all these pointers are there. We will consider it as presumptive tuberculosis. So in any case of presumptive tuberculosis, the preferred investigations, starting investigations, are to do a sputum smear examination and chest X-ray, right? Okay. Now, if the smear is positive, we call it as microbiologically positive tuberculosis, right? Or microbiologically confirmed tuberculosis if the smear is positive. If chest X-ray is showing features suggestive of tuberculosis, but sputum is not agreeing, that is the scenario this question is talking about. And when you look at this framework, right, you can clearly say that what is recommended is the Sibinat. Okay, I'll give you a vertical orientation of this flowchart later, but right now remember, if microbiologically proven, then you don't need to do anything much, right? As long as there is no pointers to think of multi-drug resistant tuberculosis, there is no such risk factors, you can jump to start treatment. But if there is risk factors for multi-drug resistant tuberculosis, even in a microbiologically proven or sputum positive, you have to go for Sibinat. If it is chest X-ray positive, sputum negative, what the RNTCP guidelines recommend is next thing to do is Sibinat. So this question is pretty straightforward to be answered based on the RNTCP protocol. We have to go for sputum Sibinat in this case. Okay, so that was my last question. I might have missed many questions from medicine because questions were not very straightforward like real medicine questions. They were really well integrated with basic sciences, and most of the questions are already being addressed by my basic sciences faculty members. But if I have missed any questions, please post those questions in the Facebook group of PW Medit so that we can discuss in the subsequent live connects. This is going to be very important for us because repeatedly I've been telling it is the topics which repeat, right? So now this question is about the RNTCP protocol for evaluation of tuberculosis. You can expect one more question on the RNTCP protocol for evaluation of tuberculosis in the next exam. The question may not be exactly same. They might give you different scenario and then ask you somewhere in the flowchart. They will leave you and then ask you what is the next step that you would be taking, right? So this becomes now the RNTCP protocol, because they've asked a question, becomes a very important topic. So if you're not able to recall the exact question, at least post the topics on which the questions were asked so that we can connect live and discuss. Okay, so with that, I'm signing off, guys. It was very nice connecting with all of you. Pukar Adhikar, yeah, I do agree. But according to me, a true medicine question is where you make a decision, like this question. It is a diagnostic decision we need to make, or a therapeutic decision we need to make, rather than like, okay, which of the following drug is likely to cause tall T waves on ECG. Those are more of a pharmacology questions only, right? Okay, but yeah, they were well integrated, and it is like maybe like faculty need to fight against each other saying that ये मेरा question है या ये आपका question है. It is good for the students, because we learn to integrate subjects well. It makes us good practitioners once we come out, if our foundation is very strong. Okay, so guys, with this I'm signing off. I will be repeatedly connecting you with various essential topics in the subsequent YouTube live sessions. If you have any specific requests, like you want this topic to be covered or that topic to be covered, please ping me on the Facebook group and we will take that up. Thank you all. Have a good night. See you soon. Thank you.